Hey everyone, and welcome to today's deep dive. I'm your host, and I'm ready to get into some really fascinating science today.
And I'm the resident expert here. Really excited to be back to break this all down with you.
So, to start us off, I want you to imagine waking up tomorrow morning and your arm simply refuses to listen to your brain.
Oh, that is a terrifying thought.
Right. You think about reaching over to grab a glass of water from the nightstand, or maybe you just want to reach out and hold your grandchild. You send the command from your brain, just like you have a million times before, but the physical action is suddenly impossible.
Yeah, it just doesn't happen.
Exactly. The arm might feel heavy or weak or just completely disconnected from your own mind. And that feeling of profound disconnect, well, that's the harsh reality for thousands of stroke survivors every single year.
It really is a devastating loss of control. I mean, the human body relies on this incredibly complex, lightning-fast highway of electrical signals. They travel from the brain, down the spinal cord, and out to the peripheral nerves.
And we just take it for granted.
Oh, completely for granted. We take that unbroken line of communication as a given until a stroke damages the brain's control center, which effectively severs the line. The machinery of the arm itself is often still perfectly intact, but it has, lost its commander.
Okay, let's unpack this. Because what if there was a way to bypass that broken line? Like, what if we could use external electricity to gently wake those disconnected muscles back up and remind the brain how to communicate with them?
That is the big question.
It is, and that is the core mission of our deep dive today. We are looking at a foundational, highly respected 2002 systematic review published in the journal Clinical Rehabilitation.
Yeah, a really pivotal piece of
It
research.
was put together by experts from the Netherlands, specifically from Roosing Research and Development and the VU University Medical Center in Amsterdam. And I should clarify, we aren't looking at some shiny brochure or marketing hype here.
Definitely not.
No, we're looking at an independent, rigorous analysis of actual clinical trials to see if zapping muscles with electricity genuinely helps people recover their arm function.
And the Netherlands has a very proud tradition of rigorous medical research. By doing a systematic review, this team didn't just cherry pick one or two optimistic studies that made the technology look good.
Right, they look at the whole picture.
Exactly. They hunted down every well-designed, randomized controlled trial they could find on this topic at the time, and they analyzed the data collectively to find the real truth hidden in the numbers.
But before we get into those numbers
Yeah.
and whether or not this actually works, I feel like we need to understand the basic mechanics first. Like, if I walk into a clinic, how is this electricity actually being used on the body?
That is the perfect place to start because in the medical world, not all electrical stimulation is created equal. There is a crucial difference between what we call functional electrical stimulation, or FES, and therapeutic electrical stimulation, which is TES.
Okay, FES and TES.
Right, and this review focuses exclusively on TES, but you can't really understand it without comparing it to FES first.
So if FES is the functional side, how does that actually work in practice?
FES is essentially a permanent or semi-permanent aid designed for continuous use. The classic example in rehabilitation is a peroneal nerve stimulator.
A coronial nerve stimulator.
Yeah. Imagine a stroke survivor dealing with a condition called foot drop. They literally cannot lift their toes while walking, which makes them trip over their own foot.
Oh, wow. That sounds incredibly frustrating.
It is. So an FES device is worn on the leg, and it shocks the muscle at the exact right millisecond of their stride to lift the foot. It's assisting the performance of a functional activity right during the stimulation.
Right.
But the catch is, if you take the device off, the foot drops again. It hasn't cured the underlying problem.
Ah, okay. So FES is kind of like riding an e-bike on your commute.
Hmm?
The motor does the heavy lifting for you so you can get to work, but it's not necessarily teaching you how to pedal harder on your own.
That is a great way to visualize it. This 2002 review, however, focuses entirely on therapeutic electrical stimulation, or TES. The goal of TES isn't just to assist you in the moment.
It's meant to be a long-term fix.
Exactly. It is a dedicated therapeutic strategy aimed at actually improving the underlying physical impairments long term. You use it during a focused therapy session with the specific hope that when you turn the machine off, take off the electrodes and go home, your arm actually functions better on its own.
And to give you a mental picture of what this looks like in the clinic, you guys, we aren't talking about implants or surgery here. The studies in this review used safe, non-invasive surface electrodes.
Just little sticky pads, really.
Yeah, they look like little sticky pads. And the physical therapist placed them very specifically on the muscles that extend the wrist and the fingers. In anatomical terms, we're talking about muscles with long names like the extensor carpi radialis and the extensor digitorum communis.
Which is a mouthful.
It really is. But why those specific muscles? Like, why the extensors?
But what's fascinating here is the biomechanical challenge of stroke recovery. After a stroke, the flexor muscles in the arm, the ones that pull your arm into your chest and curl your fingers into a fist, they often become hyperactive.
Oh, interesting.
Yeah, this is a condition called spasticity. Meanwhile, the extensor muscles on the back of the forearm, the ones responsible for opening your hand and lifting your wrist, those are often the most severely weakened.
So you basically have this brutal tug of war happening in the arm, and the muscles trying to open the hand are just losing badly.
Precisely. And those extensor muscles are absolutely crucial for everyday movements. I mean, you cannot grasp a coffee cup, or stabilize a piece of paper on a desk, or turn a doorknob if you can't voluntarily open your fingers and extend your wrists.
Look, you can't do it.
Right. So the therapy targets those specific, vulnerable extensor muscles to give them a fighting chance.
Okay, to bring back the bike analogy for a second, if FES is the e-bike doing the work for you, TES is more like having training wheels on a bike that you use in a controlled environment to actively rebuild your balance and muscle memory. The entire goal is to eventually take the training wheels off.
A spot-on analogy. And just like there are different brands and styles of training wheels, there are several different methods of applying this therapeutic electricity. The researchers in this review examined a few distinct approaches to see what actually works.
So what are the actual methods these researchers looked at? How do we convince the muscle to do the work?
The researchers broke the interventions down into four main categories. First, you have NMES, which is cyclic neuromuscular electrical stimulation. This is a pre-programmed rhythm.
Like it just runs on a timer.
Exactly. The machine is set to a timer. It turns on, sends the current, makes the muscle contract, and then turns off so the muscle relaxes. On, off, on, off.
I have to ask, because if you're telling me you're hooking my weak arm up to a battery, does this hurt? Like, are you talking about gentle tingles or a Frankenstein situation where the arm is just violently jerking around?
That is a very valid fear for patients, honestly. It is entirely safe, but I won't pretend it's a spa treatment. Depending on the intensity, it's often described as a strong, prickly buzzing or a deep vibrating sensation that suddenly forces your hand to move on its own.
Okay, so a bit jarring.
Yeah, it can be startling and mildly uncomfortable, especially at first, but it shouldn't cause acute pain.
Okay, so that's the cyclic NMES. What were the other methods?
Then you have 10NS, which is transcutaneous electrical nerve stimulation. Many people have actually bought small 10NS units at the pharmacy for lower back pain.
Oh yeah, I've seen those.
Right. In stroke rehab, they adapt it, often tweaking the frequency to evoke muscle contractions rather than just blocking pain signals. Then we move into the more advanced therapies, PFST, which stands for Positional Feedback Stimulation Training, and EMG-triggered electrical stimulation.
Wait, positional feedback. Does that mean the machine actually knows where my wrist is in space? How does it feed back to the muscle?
Yes, exactly. With positional feedback, the device uses sensors to monitor the angle of your wrist. It essentially rewards you with electrical stimulation when you move your limb into the correct position.
Wow, that's smart.
It is. It provides real-time physical feedback based on your actual movement.
That is incredibly clever. So they took all these different methods, the cyclic rhythms, the 10NS, the positional feedback, and they examined 6 high-quality randomized controlled trials. That covered over 200 stroke patients in total.
A solid sample size for this kind of review.
Yeah, and the bright side here is pretty bright. Out of those 6 studies, 4 showed that people using the electrical stimulation made significantly better progress than the patients in the control groups who just did standard physical therapy.
And we aren't talking about a tiny, barely measurable clinical difference either. In the studies where the researchers could actually calculate the size of the effect using a statistical measure called Hedges G, the results ranged from 0.55 to 1.46.
Which in statistics land means what exactly? Because to me, 1.46 just sounds like a tiny number.
I know, it does sound small. But to put a 1.46 effect size into perspective, it is a massive gap in clinical research. It means the average stroke survivor who used this electrical therapy ended up with better motor control than over 90% of the survivors who only received standard therapy.
Over 90%.
Yeah. An effect size of 0.55 is moderate, but anything over 0.8 is considered large. So a 1.46 is an overwhelming signal that something very positive is happening in that arm.
I hear what you're saying about those numbers, but I do need to push back on this a little bit, because as I was reading through the review, the authors clearly state that the evidence for functional abilities was severely limited in 2002.
That's true.
Only 2 of the 6 studies even bothered to measure functional ability, and only 1 of them showed a positive effect. If I'm a patient and my goal is to hold my grandchild, I might be pretty frustrated if my doctor says, well, the statistics say you improved, but you still can't pick up the baby. Is there a risk we are celebrating a clinical win that doesn't actually matter to the patient's daily life?
Well, if we connect this to the bigger picture, we have to separate the concept of functional ability from what the other 4 successful studies were actually measuring. You are completely right that the ultimate goal is holding the grandchild or drinking a cup of coffee. But those 4 studies measured motor control.
Motor control.
Huh.
How is that fundamentally different from function?
Motor control isolates the specific physical impairment. It's measured by very specific clinical tools, like the Fugl-Meyer motor assessment.
The Fugl-Meyer.
Right. During a Fugl-Meyer test, a doctor isn't asking you to make a sandwich. They're asking you to perform isolated voluntary movements. Can you lift your wrist against gravity? Can you straighten your elbow? Can you open your hand?
So it's the micro, not the macro.
It is the absolute foundational building block of movement. If you lack the voluntary motor control to lift your wrist or open your fingers even a fraction of an inch, then complex functional tasks like picking up a coffee cup are completely impossible.
You can't run before you can walk.
Exactly. The review showed that therapeutic electrical stimulation significantly improves that underlying motor control. You cannot build the house until you pour the foundation.
Okay, I see the logic there. You have to learn to flex the muscle before you can learn to use it in daily life. And if motor control is the foundation, it makes me wonder who is best equipped to build on it. Because the data actually reveals a really fascinating pattern about who benefits the most from this therapy.
It does, and it comes back to those advanced methods of stimulation we mentioned a moment ago, specifically the difference between the passive cyclic approaches and the active triggered approaches.
Right. This was a major distinction in the studies that really caught my eye. Some used that simple cyclic EMS. The machine is completely pre-programmed. It sends those gentle electrical pulses to make the muscles contract rhythmically. You could theoretically be sitting in the clinic, watching TV, totally zoned out, and your arm is just twitching to the beat of the machine.
Just completely passive.
Yeah. But the other studies use what they call triggered versions. This includes the EMG stimulation and the positional feedback. How does an EMG trigger actually work?
The triggering mechanism is where the science gets incredibly elegant. EMG stands for electromyography. The electrode placed on the arm isn't just pushing electricity into the muscle, it is actively listening to the muscle.
Listening to it.
Yes, it is waiting for an electrical signal from the patient's own nervous system. That means the therapeutic stimulation only kicks in when the patient voluntarily tries to move their muscle and passes a certain threshold of effort.
Here's where it gets really interesting, because combining the patient's own intense mental effort with the electrical assist seemed especially promising. And that led to a major discovery when the researchers dug deeper into the data.
They performed what's called a post hoc subgroup analysis in 2 of the studies, the Sonday study and the Powell study.
And a post hoc analysis is basically looking backwards.
Yeah, exactly. It simply means they looked back at the data after the trial was over and divided the patients up into different groups based on how severe their stroke was to see if patterns emerged. What they found was that patients who still had some residual movement left in their arm, the ones who could generate a tiny bit of voluntary effort, responded far better to the stimulation than those with severe complete paralysis.
It makes total sense. It's less like jump-starting a completely dead car battery and more like power steering in a heavy truck.
Yeah.
You still have to do the mental work of turning the steering wheel. If you just sit there with your hands in your lap, the truck isn't going to turn itself.
Right.
But once you start trying to turn the wheel and the machine senses your effort, it kicks in with the extra force you need to actually move those heavy tires.
That is exactly the mechanism at play. It requires that active mental effort from the brain trying to reach the muscle, and then the machine provides the electrical assist to finish the job. It's a true partnership between the human nervous system and the machine.
It's pretty amazing.
It is. You can see why modern rehabilitation has moved so heavily in this direction, combining electrical stimulation with active, voluntary task practice. But, as promising as that sounds, We cannot ignore the flaws in the data.
Oh, absolutely.
We have to view these 2002 findings with a critical scientific eye, and the researchers who wrote this review certainly did.
They really did. They did not pull their punches when it came to critiquing the studies they were analyzing.
Not at all. They assessed the methodological rigor of all 6 trials using a standardized 19-point scale. The study scored anywhere between 7 and 16 out of a maximum of 19. So there were absolutely vulnerabilities in the way some of this research was conducted.
Let's talk about the biggest vulnerability, because it's something that makes researching physical therapies so much harder than researching a new pharmaceutical drug. It's the placebo problem, or specifically the blinding problem.
In a gold standard trial, you want to compare your active treatment against a placebo to prove that the biological treatment itself is what's causing the improvement, not just the patient's psychological belief that they're being treated.
Right, the placebo effect is strong.
Very strong. With a drug trial, it's relatively easy. You give one group the real pill and one group a sugar pill. Neither group knows what they took. That is blinding.
But how do you blind a patient to electricity snapping their wrist backward? You stick an electrode on their arm. Either the electricity fires and forces their hand open, or it doesn't. You can't really do a sham stimulation, right? Because the patient in the control group is going to immediately realize they aren't getting the real treatment when their arm just sits there doing nothing.
The risk of unblinding is massive in these trials. The researchers note that while you can technically apply sham stimulation, maybe a tiny tingle that doesn't cause a contraction, the absence of any real motor reaction means patients instantly realize they've been allocated to the control group.
They figure it out right away.
Exactly, and without blinding, the results can be heavily biased. A patient who knows they are getting the cutting-edge experimental therapy might try harder during their regular exercises. A patient who knows they got the sham device might feel demoralized and put in less effort.
Which brings up another huge question about the results. Is there a chance the electric stimulation wasn't the only thing helping the experimental group improve their motor control?
This raises an important question, and it's perhaps the most critical caveat in the entire review. In 4 of the 6 trials, the experimental group received standard physical therapy plus the therapeutic electrical stimulation. The control group just got the standard therapy.
Wait, really? So the group getting the electricity was just getting more therapy overall, like literally more time in the clinic?
Yes. The researchers call this a contrast in intensity of therapy. It is a known, incredibly frustrating bias in rehabilitation research. Did the patients in the experimental group improve because of the unique physiological properties of the electrical stimulation? Or did they improve simply because they were getting more overall attention, spending more time with the therapists, and experiencing a higher intensity of therapeutic intervention?
That is a big problem.
The reviewers honestly admit that this contrast in intensity could be responsible for the positive effects seen in those trials.
Well, that is a massive clinical ambiguity. How do we know it wasn't just the extra time and human interaction? I know they tried to compensate for it in some studies by having the control group do extra voluntary wrist exercises, or even just having the physical therapist visit them extra times to chat about their progress, just to equalize the amount of attention they were getting.
Right, they tried to balance it out.
But that still feels muddy.
It is muddy. Clinical research involving human behavior and physical therapy usually is. And yet, despite the methodological challenges of blinding and therapy intensity, the expert reviewers still concluded that there is a legitimate, positive signal here. Even accounting for the flaws, the evidence strongly suggests that therapeutic electrical stimulation improves motor control.
So what does this all mean? We need to bring this back to what it means for you, the listener, or maybe a family member who is currently navigating life after a stroke today. Because it's easy to get lost in the statistical weeds and the methodological flaws of a 2002 clinical review. But at the end of the day, people just want to know how to get their arm back.
The overarching takeaway is that therapeutic electrical stimulation is not a magic switch. It is not a cure-all that will fix a paralyzed limb overnight, and it absolutely does not replace the hard, grueling, exhausting work of traditional physical and occupational therapy.
But it is a legitimate research-backed tool for the electric toolbox. We know from the science that it helps prevent muscles from wasting away from disuse. We know it improves strength and the range of movement. And perhaps most importantly, it gives the brain repeated, useful physiological signals to help it relearn how to control the arm.
Stroke recovery is a deeply personal journey. What works wonders for one person might need significant adjusting for another, which is why these technologies should always be explored under the guidance of doctors and physical therapists. But understanding the science behind the treatments available to you is incredibly empowering.
It truly is. Recovery is rarely a straight line. There will be plateaus and setbacks, but every bit of motor control you can claw back, every single degree you can voluntarily lift that wrist or wiggle a finger, is a foundational victory. Small improvements in that underlying motor control can and do lead to bigger wins and functional independence down the road.
And exploring this topic leaves me with one final fascinating thought, one that I think completely flips how we normally view stroke rehabilitation.
I'll lay it on us.
The sources mention that stimulating the muscle gives the nervous system repeated, useful signals to help it relearn control. Normally, we think of the brain as the absolute master commander. The brain heals, and then it tells the body what to do.
Right.
But with technologies like EMG-triggered stimulation, where the physical movement of the wrist sends sensory feedback back up the spinal cord to complete the circuit, how might this change our fundamental understanding of healing? Could it be that in the journey of recovery, it's actually the muscle that is rehabilitating the brain?
Wow. That is a wild thought to leave on. Because if the muscle can actively teach the brain how to fire again, then that arm that refused to listen to you when you woke up this morning, it might not be a lost cause at all. It might just be waiting for the right kind of spark, the right kind of power steering to start the conversation again.